The effect of palliative care on the existential factors that mediate quality of life. Many individuals today live with a serious disease or life-threatening condition, such as heart disease, cancer, or neurodegenerative disease. The burdens associated with these illnesses cause concurrent suffering that is not easily addressed through traditional methods. Nevertheless, these secondary effects of illness can have a profound effect on healthcare decision-making. For example, the desire to hasten death, or DHD, influences patients' choice to pursue physician-assisted suicide and euthanasia. Although many studies have demonstrated DHD's resilience to standard treatment, the literature indicates a strong negative correlation between DHD and quality of life. One study identified poor perceived quality of life as the most cited reason for DHD. These studies have also shown that quality of life primarily is mediated not by pathological symptoms, but by existential concerns, such as loss of autonomy, loss of dignity, inability to engage in activities that make life enjoyable, and becoming a burden. Consequently, quality of life has been described as a more abstract and multidimensional concept than pain or fatigue, involving intellectual and cognitive, social, and spiritual domains. Increasingly, quality of life is being integrated into standard treatment through palliative care, which optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum of illness addresses physical, intellectual, emotional, social, and spiritual needs, and facilitates patient autonomy, access to information, and choice. Existential mediators of quality of life can be treated through a variety of interventions, including meaning-based therapies like dignity therapy, social support, symptom management, and education about illness. The literature also emphasizes early diagnosis of the underlying pathology. DHD ranges from 8.5% to 17% in patients receiving palliative care. According to Death with Dignity data from Oregon and Washington State, the majority of patients who participate in physician-assisted suicide suffer from cancer, 78%, neurodegenerative disease, 7.4%, heart disease, 6.4%, or respiratory disease, 4.8%. These individuals tend to be 65 years of age and older, white, well-educated, and less religious. The integrated behavioral model's influence on existential constructs like attitude, norms, and perceived agency make it an ideal model for describing quality of life. However, the IBM emphasizes that these constructs are not likely to influence behavior unless they are supported by a person's skills and environment. For example, Tamil et al. Educated participants on their illness, helped clarify treatment goals, and provided the expertise needed to make informed medical decisions. The following two studies illustrate the mediating roles of the IBM's existential constructs on quality of life. Enable is a telephone and manual-based intervention. In one study, 11 patient-caregiver dyads received an initial palliative care construction, followed by 6 weekly coaching sessions and monthly follow-up calls until death. The study emphasized existential factors related to care, namely attitude, norms, and perceived agency. Coaching sessions targeted attitude and perceived agency through sessions on advanced care planning, life review, and creating a legacy. Patients' personal agency was increased through counseling on problem solving, symptom management, self-care, decision-making, advanced care planning, and patient activation. Given the interpersonal and multidisciplinary aspects of palliative care, communication mediates the effects of the other elements. 3 primary themes emerged during satisfaction interviews. 1, that the program would have been more helpful if initiated sooner. 2, that patients found it beneficial to have someone to talk to and receive advice from. And 3, that the volume of information needed to be reduced. In this lung cancer study, patients met with members of the palliative care team within 3 weeks of enrollment and at least monthly until death. Counseling addressed attitude through sessions on symptom management and coping, perceived norms through symptom management and coping, and personal agency through education, symptom management, coping, and decision-making. The intervention emphasized knowledge and skills almost as much as attitude, norms, and agency. In addition, it placed a slightly greater emphasis on the environmental constraints than the enable did. Quality of life was significantly improved in the intervention group compared with the control group. Fact L, 98%, 98 versus 91.5, p-value equals 0.03. Similarly, fewer patients in the intervention group displayed depressive symptoms, 16% versus 38%, p-value equals 0.01. Interestingly, palliative care did not have a significant effect on symptom management between the intervention and control groups, which supports the hypothesis that it should focus on the existential aspects of care. The social capital framework describes the relationship between well-being and social networks. Environment and social context has a considerable influence on the existential factors related to end-of-life care, and therefore complements the individual-level IBM-oriented interventions. The four elements of the SCF are access to close or patient and caregiver networks and relationships, intra-community and formal care networks outside the family, such as home care services, inter-community networks that include community groups and programs, and partnerships with government agencies. The following study demonstrates the effect of social networks and support on the existential factors that influence quality of life. This study integrated a palliative care team into an ICU in the Bronx, a predominantly minority, low-income borough in New York City. The intervention addressed the barriers faced by this community, particularly social asymmetry, which creates social and care-related barriers. For example, the perceived weakness of entering palliative care and the misconception that palliative care is lower quality care. Consequently, the palliative care team developed a culturally sensitive approach to end-of-life care, which it delivered through family meetings. Many of these meetings focused on educating participants about illness and incorporating cultural values and traditions into end-of-life decision-making. Trusted members of the patient's social networks, such as clergy, were invited to participate in these conversations. Discussions addressed symptom management, withdrawal of life-sustaining treatment, goals of care, and hospice referral, emphasizing communication and psychosocial, cultural, and spiritual factors. Based on the goals and values identified during these meetings, the palliative care team approached service organizations at the intra- and inter-community levels, such as home care and hospice agencies, to assist the primary caregivers. Outcome tests and family focus groups point to the importance of psychosocial assessment and social support. The proportion of patients who completed advanced directives increased from 33% to more than 80%. In addition, the utilization of non-beneficial laboratory and radiological procedures decreased. Some patients also made use of pain medication to increase comfort. The IBM accurately identifies existential factors that influence quality of life. Patient feedback during Enable stressed participant satisfaction with the final 3 sessions, which focused on reevaluating attitudes, norms, and agency in light of the realities of illness. In the words of one participant, it kind of helps you put things in perspective, and it changes your attitude more towards life, hopefully giving you a more positive outlook. As noted in the description of the lung cancer study, Fact L scores reflected improvement in emotions and well-being, and HADS showed improvement in depression. Enable effectively mitigated the environmental constraint of geographic dispersion by offering telephone-based consultations. The lung cancer study suggests that early implementation of palliative care decreases environmental barriers by facilitating earlier access to community support like healthcare services and hospice. Since the end of life is a stressful time, the IBM's most obvious flaw is probably the absence of coping strategies. Nevertheless, the lung cancer study specifically incorporated coping into its intervention. The micro and meso levels were the most useful constructs of the SCF. Regular family meetings emphasized communication in the language of the patient and family, and accommodated cultural traditions related to the dying process. This was assisted by the inclusion of trusted members of the patient's intra-community network, such as clergy, and the decision-making process. At the inter-community level, hospice referrals increased by 70%, easing the burden of caring for patients at home in the absence of strong social support, comprehensive insurance, and adequate living situations. Similarly, the palliative care team accommodated families' environmental barriers by establishing flexible visiting and consultation hours around their work schedule. Although the intervention focused on creating strong, culturally sensitive communication between the healthcare team and patients, it did not resolve divergent clinician-family perspectives regarding symptom management, peacefulness, and ability to say goodbye. In addition, shared decision-making may have increased the possibility that treatment was either prematurely discontinued or unnecessarily prolonged. Family focus groups also indicated the need for more education and earlier access to palliative care once the patient was admitted to the ICU. Existing palliative care interventions can be improved by 1. Incorporating a multi-level meaning-based care program, and 2. Distributing care functions among community organizations for ambulatory patients. Intra and intercommunity groups such as churches and community clinics can provide meaning-based consultation. These organizations are more likely to understand the patient's psychosocial, cultural, and spiritual needs. This enables the palliative care team to concentrate on the medical aspects of care, such as pain and symptom management, and coordinating patients' care program. In addition, integrating community organization into the care team removes some burdens of cost from the patient and healthcare system. Some states offer similar assistance and may be able to provide funding and home care or social services. Decentralizing palliative care early in diagnosis can set the context for patients' expectations about quality of life. For example, by emphasizing that patients are being accompanied by a member of their community, not cared for by a medical professional, consultation can mitigate patients' perceptions that their dignity is decreasing or that their burdensomeness is increasing as their condition deteriorates. At the beginning of the intervention, the palliative care team establishes the patient's values and goals through an initial assessment. Symptom management and illness education remained unchanged from previous studies. The palliative care team arranges for a pastor, nurse, or social worker from an organization in the patient's community to counsel him or her on the existential factors that mediate quality of life. Ideally, community members would be trained to advise patients on advanced directives, although this is related closely enough to treatment that this service could be provided by the palliative care team. Progress, perceptions, and goals are assessed at regular meetings between the palliative care team, the patient and his or her family, and community providers. Regular communication will also enable the patient and his or her caregivers to determine the appropriate time to approach other inter-network organizations, such as home care and hospice. This intervention magnifies the positive effect of palliative care by tailoring existentially oriented interventions to the circumstances of individual patients and utilizing a greater proportion of palliative care resources available in the community. This model emphasizes the pathways through which patients determine their quality of life. The intervention influences existential factors through meaning-based therapy and spiritual support, and biological and psychological factors through treatment. These outcomes influence patients' perceived agency and attitude, which in turn determine their quality of life. Quality of life, environmental barriers, and knowledge and skills influence DHD. In addition to directly influencing DHD, knowledge, skills, and environmental barriers indirectly influence quality of life. This illustrates that although quality of life is the most significant determiner of DHD, it does not exist in a subjective vacuum of agency and attitude, but is highly dependent on environmental factors. Thank you very much for listening to my presentation, and I look forward to hearing your comments on it. Thank you very much. Have a good afternoon.